Welcome everyone to our webinar, A West Coast, East Coast Shared Passion for ICU Early Mobility, Reducing Morbidity, Including Falls, facilitated by the Fall Prevention Community of Practice. My name is Mariel Ang, and I am the project coordinator at the Ontario Neurotrauma Foundation. ONF sponsors the Fall Prevention Community of Practice and its online platforms, Loop and Loop Junior. Marguerite Thomas also joins us on the line. Marguerite is the consultant liaison for the Loop Fall Prevention Community of Practice. She'll be assisting with facilitating the chat box and Q&A today. Before we begin, I'd like to give you a rundown on the Zoom meeting platform. These screenshots may look a little bit different depending on the type of computer you are joining us from today. If your Zoom application is opened in full screen, you can double-click or press the escape button on your keyboard to exit the full screen. There should also be a button in the top right corner of your screen that says Exit Full Screen. On this slide, you can see that I've circled in red where the Exit Full Screen button can be found. The webinar technology consists of two parts, audio and visual. Both visuals and audio are provided through your computer, monitor, and speakers. To test audio settings, look for the Audio Settings or Join Audio button in the bottom left corner of your screen. This will provide options for testing your computer, microphone, and speakers. To adjust your audio settings, click the Audio Settings button in the bottom left corner. If you look at the bottom center of your screen, you will see buttons that will allow you to access the chat box, raise hand, and Q&A features of Zoom. The chat box allows you to send messages to the webinar presenters. You can use the raise hand button if you want the presenter to connect with you through the chat box. You can also submit questions through the Q&A box. If you need to leave the webinar anytime, click the red Leave Meeting button in the bottom right corner of your screen. If you have any questions about the technology at any time during this presentation, please type them into the chat box or use the Q&A feature on the Zoom software. Alternatively, you can email me at mariel@onf.org and I'll work with you to resolve technical issues as soon as possible. If you have topic-related questions during the presentation, please type them either into the chat box or the Q&A feature. During the Q&A session at the end of the presentation, questions will be read aloud to the group. The webinar is being recorded and a YouTube link will be sent to all participants in about 1 week along with the presentation slides. I would now like to introduce our presenters, Karen Webb-Anderson and Sarah Crow. Karen is a registered nurse with experience in critical care, air medical transport, clinical teaching, research, and accreditation. In 2014, Karen found a new position as the quality leader in critical care in Halifax. Recently, Karen has taken a clinical leadership role in a provincial smart pump infusion project. Sarah Crow is a nurse practitioner in critical care at Fraser Health. She was previously the clinical nurse specialist for critical care and was responsible for creating and leading a number of quality initiatives. Sarah's passion lays in caring for patients and families experiencing critical illness in an effort to improve PICS and enhance survivorship of this vulnerable group. Without further ado, please take it away, Karen and Sarah. You may now share your screen.
Okay, let's see here if I can get this done correctly. Okay.
Perfect. We're able to see your screen now, Karen.
There, you can see it now?
Yeah.
Excellent. Whatever I've done, I can no longer see the Q&A. So I'm assuming everyone else can keep on top of that. My name is Karen, and Sarah and I are going to talk to you today about our passion for ICU early mobility. We want to thank you for inviting us and giving us this opportunity to share this work that we're so passionate about. Neither of us have any disclosures. We would like to acknowledge the Canadian Association of Critical Care Nurses for the networking opportunity that has initiated this shared work and made a lot of great connections across the country, including the relationship between Sarah and I. The goals of today's presentation are to provide a brief description of the evolution of critical care medicine, to describe a bundle approach to best practice in critical care, to talk about how falls prevention is embedded in the philosophy of early mobilization in ICUs, and to share the Fraser Health in British Columbia and the Nova Scotia Health experience. So the evolution of critical care. So since the inception of ICUs, there have been dramatic improvements in the care of the critically ill. It used to be that in pretty much all the research, if you pull out any research study, the key indicator was always the mortality rate. The 30-day mortality rate was sort of one of our big factors that we always measured. And it's still important to us, but we have now realized that as more and more of our patients are surviving their ICU stay, as that mortality rate improves and improves, that we are now focusing more of our research and more of our care initiatives on the morbidity associated with ICU or with critical illness. So that's shifted our focus both in the clinical setting and in the research world towards how do we minimize those complications and how do we mitigate the impact on patients and families' quality of life and their long-term outcomes. The impact of critical care is vast, and it goes from, just every part of the patient and their family. Some of the more common complications relate to hospital or ventilator-acquired pneumonia, delirium, which we'll talk a lot about today, muscle wasting, depression, pressure injuries, and immobility and falls being a big piece of this. We now have a syndrome called post-ICU care syndrome, and I'm not sure how many may have heard of that. There's still lots of us in the critical care world that it's a new term, although we might recognize it, but we're not always familiar with the term. It's a group of symptoms that are collectively known as PICS. We just shorten it to PICS, and it's defined as any new or worsening impairment in the physical, cognitive, or mental health status of our patient arising after the critical illness and persisting beyond discharge from acute care. So this is something that is a result of the critical illness, but that's actually seen after they leave our doors. It's associated with pretty much everything that we do in the ICU. So the cognitive impairment is associated with, and I won't read all of these, I know it's a busy slide, but the cognitive impairment is associated with ICU delirium. That's a big one for us. Acute brain dysfunction, often associated with alcohol or strokes. Hypoxia, which lots of our patients have hypoxia at some point during their stay with us, and hypotension as well. A lot of our patients have hypotension. Glucose dysregulation, all kinds of our patients have that for a multitude of reasons. Problems breathing, prolonged ventilation, sepsis, that's still one of our #1 reasons for coming into the ICU, and prior poor cognitive function. So if they had a pre-existing cognitive deficit, older age, or pre-morbid condition. The mental health impacts are often associated with everything that was in that cognitive impairment bucket, plus there's been shown to be associated with a greater degree of mental health impact with female gender, lower education level, pre-existing disability, use of sedatives and analgesias, and we do lots of that. And then the ICU, the physical acquired weakness is most strongly associated with prolonged ventilation, sepsis, organ failure, and sedation. So what do these patients experience? They experience a combination of any of the impacts within those 3 domains, and they can be, you can have PICS and have the impact in one of those domains. You don't have to have all 3. The most common symptoms are generalized weakness and fatigue, decreased mobility, anxiety, mood depression, sexual dysfunction, and cognitive problems. So poor memory, slow processing, impaired concentration, like the just inability to, go into the grocery store and not be able to remember what you came for the grocery store. And that was never a problem before. Just almost being incapacitated. I'm going to make lunch for my grandson. I can't even remember how to make that sandwich. So these sort of cognitive and impaired concentration, and it can last from months to years. There's a couple of links if this is an interest of you, and if you work in acute care, and I think as you listen to Sarah and I speak, you're going to go, oh yeah, I've seen this before in my patients. There's some excellent videos on YouTube of the patient's experience, and I encourage you to go on there and just put post-intensive care syndrome in. You'll find all kinds of great videos of patients' experience. So post-intensive care syndrome and delirium. So this is a big one for us. So delirium is estimated to impact between 60 to 80% of ventilated adult ICU patients. It's associated with many adverse outcomes, including mortality, falls, functional decline, cognitive impairment, and it drives our healthcare cost, obviously. In one study on a chart review after falls, 96% of inpatient falls were associated with delirium. And delirium experience while a patient is in the hospital results in a 6-fold increase in their likelihood of falling after they get out of hospital. So delirium is a big impact on our patients, a lot of morbidity and true association with their falls risk. So, I've talked about all those factors that impact that is tied up into PICS, and I've talked about a little bit about delirium, and then we think about, so if we want patients to do better, how are we going to mitigate this negative impact of PICS? And Sarah's going to talk to us a little bit about some of the strategies that we use in the ICU.
Hi, everybody. Can you hear me?
I can hear you, Sarah.
So hopefully everybody else can.
Hear you, Sarah.
Great. Hi, I'm Sarah Crow. Thank you again for inviting us. And I'm just going to talk a little bit about the evidence-based practice and the bundle approach that we use in critical care. So historically, there was little risk of falls in the ICU as the patients were sedated on bed rest. And now as our culture has started to move towards waking and moving more, we must be attentive to doing this safely. So integrating care early into the ICU as a strategy to tie together a bunch of different best practices has been really important. And one of the things that we've really struggled with was how do we shift culture in ICU from a model of being protective of our patients, the idea that they're too sick to get out of bed, and try and shift that to, well, they're stay in bed. So this has been an ongoing area of work in critical care for the last number of years. There's lots of different guidelines and groups out there that talk about how to do this safely. The ICU Liberation Group is one of the big ones, and they have approached it with an ABCDEF Bundle approach. Basically, if we can mitigate and prevent post-ICU care syndrome and delirium, we actually are going to improve outcomes in our patient population. So we've really focused on sort of a back to the basics approach, a less is more approach, less drugs, less ventilation, less sedation, less bed rest. Really trying to focus on improving pain management, agitation, preventing delirium and mobility, and disrupted sleep. Next slide, please. So what is our ABC bundle approach? So it really is a very basic way of looking at things. So it really is assessing and preventing and managing pain. We know that ICU patients have a tremendous amount of discomfort just from being ill, being in a bed, having lots of tubes and wires and different things attached to them. And often unmanaged pain actually leads to agitation, which leads to delirium. So we've been really proactive on improving our assessment, prevention, and management of pain. B is for breathing. And so it's both spontaneous awake trials, or SAT, and spontaneous breathing trials. So what this means is that we all can imagine the ICU patient and what they're going through, and many of you may have even thought, well, if I was ever in that circumstance, I hope they just knock me out until I'm better. And that's been the mindset for a long time. But we're now moving away from that because we're realizing not only is it creating post-ICU care syndrome, but it's keeping people in bed longer, in ICU longer, on ventilation longer. So spontaneous awake trials are looking at targeting the sedation that we're using, and so reassessing daily either by minimizing it or turning it off to see how the patient's responding and if they still need that sedation or not. And then the spontaneous breathing trial, once they're past their acute phase of whatever's brought them in, is really looking at, can they spontaneously breathe on their own? So it's minimizing the help of the ventilator, so we can really be assessing daily, do they need this? And so we can get rid of the ventilator as quickly as we can. C is choice, so choice of analgesic and sedation, really closely tied to our A for assessing pain. We're really looking at our choice of analgesic. A lot of times, really well-intentioned, we reach for narcotics first, but really being more proactive and looking at different non-opioid choices first. So looking at, maybe it's just Tylenol the patient needs and they need it regularly in order to control that pain. Looking at choices of sedation, so not using infusions, but perhaps just small bolus dosing, and then really trying to get away from using benzodiazepines in the ICU unless that they're really warranted, such as in alcohol withdrawal cases. We know that benzodiazepines in many of our patients is very deliriogenic and will cause delirium in many of our vulnerable patients. The next is D, delirium, so assessing, preventing, and managing. Delirium is such a huge burden on patients in the ICU. Like Karen mentioned, upwards of 80% of our patients are found to have some form of delirium, and the challenge has really been trying to get staff engaged to look at the different forms of delirium. So we often, when we think of delirium, we think of the really restless, the really agitated, confused patient, and that's a hyperactive delirium, and that one is really easy to assess and to catch. But the other forms of delirium, the hypoactive, are the patients who all of a sudden have a really flat affect. They're very withdrawn, they're tired, they're bed-seeking, they just want to be left alone. And this is a real challenge because a lot of times it's easy to care for these patients because they really don't want much interaction. But it's trying to key staff into this isn't normal behavior. And we actually really need to be watching for this hypoactive delirium because it's actually much more common than the hyperactive. And then the third kind of delirium is a mixed. So it's both the hypo and the hyperactive. And many of you may have witnessed this as sundowning syndrome. So patients who become delirious or agitated at night. They seem okay or a little bit sleepy and flat during the day, but once, later on the late afternoon, early evening, they become really, really restless. So it's this mixed delirium. So having a good tool to assess, and there's a few different ones out there depending on the environment that you work on. Preventing, as I move into E, early mobility, is really the only way to prevent delirium. And then managing it is trying to keep the patient as safe as possible and trying to mitigate some of those symptoms as they go through it and try and get them through as quickly as possible. So E of the bundle is early mobility and exercise. Like Karen was stating earlier, many of the falls that do happen are closely tied to delirium. So if we can get patients moving early, more often, having regular exercise, this can actually prevent delirium. It can also prevent muscle wasting and then thereby reducing falls. And the final part of our bundle is F, so family engagement and empowerment. So really letting family know what's going on, what to expect, trying to give them education about not only the ICU stay, but things like delirium and post-ICU care syndrome. Really giving them knowledge will help empower them and help them be less scared when they see their loved one going through a delirium and not understanding what or why it is. Family can also be engaged to assist in early mobilization and exercise, and actually is a very powerful tool to help give them something meaningful that they can focus on and feel like they're part of the care team. Next slide, please. So early mobilization, like I said previously, this is one of the few therapies that we can actually do as critical care nurses to help reduce post-ICU care syndrome, and in the general population can also help reduce the risk of falls. We know that our bedridden patients have an increased risk of death and other complications such as delirium, muscle wasting, which also includes heart deconditioning, ICU-acquired muscle weakness. Patients who have prolonged ICU stay actually have polyneuropathies that cause profound muscle weakness that isn't really understood at this point, but we're working really hard to come up with therapies to try and prevent skin breakdown, pressure-related injuries, pneumonia, insulin resistance, and then just an overall poor quality of life as well. Next slide, please. So the evils of Bedrest and immobility. Bedrest promotes immobility of the muscle fibers that can actually lead to shortening length of the collagen, causing contractures and reduced functioning in the limbs. And these can occur very quickly in as little as 2 to 3 weeks of immobility. This is key because as patients develop muscle contractures and immobility, they're at risk for falls. And when we add in a delirium, which may have poor cognitive functioning and that impulse control, this is a danger for falls. So patients who are now weak, have poor cognition, are making unsafe choices, and are being very reactive. So they're jumping out of bed because they're trying to get a glass of water. They're jumping out of bed because they want to, go look at the window, not realizing what the immobility has done to their body. And these patients are at a huge risk for falls. There's definite cardiovascular side effects of being on bed rest too. So like other muscles, if you don't use it, you lose it. So your heart muscle, as you're staying in bed, you will become deconditioned. Leading to decreasing your cardiac output, elevated resting heart rate. These all affect also your receptors in your body, which will lead to worsening postural hypotension and tachycardia, which you can imagine too, that if you have somebody who's delirious, weak, and is now, getting out of bed unsafely with potential hypotension, this is all compounding and causing more risk for falls as well. Next slide, please. So just really basic. So immobility increases your risk for delirium. There's profound long-term side effects, your weakness, self-care deficits, poor quality of life, and an increased 5-year mortality. We know that some of our patients who become delirious and are on prolonged bed rest don't make full recoveries. And that at the crux of it is why we need to get our ICU patients moving. Next slide, please. When I've done my work on mobility in ICU, I've often started with asking staff, what do you picture when you think about mobility? And most of us, when we picture mobilization and getting patients moving, we really think about having people up and walking, trying to get them back to their baseline. It may include, some assistive devices such as walkers, but really when we picture mobility, we picture walking. Next slide, please. Part of my goal in my role in trying to engage people was really to challenge staff to think beyond traditional mobilization and to think about the other things that we can do. So specifically in ICU setting, it is hard to get our patients up and walking, but there are so many things that we can do that are also forms of mobility that I think staff don't recognize or realize the benefit. So this may be doing weights in bed, free weights. This may be doing the arm bike in bed. This may be doing the tilt table or using slings and lifts, different things to try and get patients mobilizing. A lot of this is dependent on having equipment to support the patients. So really looking at what different adjuncts can help support patients move. Things like tilt tables or the Avia walker that helps to keep all the ICU equipment together to provide easier mobilization, to hand weights. And then also I've had people say to me, well, Sarah, we don't have any of this stuff. So we can also look at doing things more simply. So if you don't have arm weights, I've encouraged staff to use IV solution bags, anything to try and get patients moving, changing position, getting patients up to the chair. All these things are very simple. We don't necessarily always consider them to be mobilization, but these changes of position, engaging different muscle groups is all mobility, and it all makes a difference. Next slide, please. And then, of course, we definitely had to share a picture of us walking an ICU patient. So as well, we do a lot of innovative things in the room, in the bed, but we do get patients up and walking. It takes a whole team. It's a very coordinated approach, but these patients do so much better if we can get them up and walking. Not sure if you were familiar with ICU, but what you can see on the screen right now is actually a lady who is still intubated. She has a ventilator, breathing tube attached. She has central lines and feeding tubes hanging down the front of her gown. She's got the team around her. There's somebody behind her that's following with a chair. And in case she does get weak, she's got the walker, the staff on either side of her. And then, of course, there's going to be other people in front of her controlling the ventilator, controlling the portable monitor to make sure that she's safe. Next slide, please. So in Fraser Health, we decided that we really needed to do more about mobility. We wanted to focus on improving patients' long-term outcomes. Like Karen was saying, it's not enough just to get our patients to survive the ICU stay if their state of health is so poor when they survive it that they have no meaningful quality of life. So we really started trying to get staff buy-in to try and get them focused on mobilizing patients, really trying to dispel the myth that the patients are too sick to mobilize, that there's not very many options available, or that it's dangerous. We're looking not only to inspire the ICU nurses, but to be a role model for the hospital and for the whole healthcare system, because really, if we can mobilize ICU patients, any patient can get up and move. Next slide, please. Our first big mobility quality improvement project was called Mobilize Me. So it was a project that we initiated at our at a 26-bed ICU that was, our whole goal was to get every ICU patient mobilizing every day, even if it meant we had to move mountains to get it to happen. We really focused on helping staff identify a barrier versus a true contraindication, and we aimed at having every patient move every day. Next slide, please. And to do this, we had to identify the challenges. And so a lot of our staff would tell us a variety of different things that, cause them to not be able to move their patients. So we really had to look at, is this a barrier or is this a true contraindication and it was unsafe to do so? We found that most of the time, things that we thought were contraindications were really just barriers. So looking at whether the patient maybe has to go for a CT scan is not a contraindication for mobility, it's a barrier. And we can arrange our day better to do both the CT scan and the mobility. Looking at the amount of equipment attached to the patient, it's a barrier. Maybe we need to have different tools like specialized walkers and mobility aids, but we can actually still get the patient moving. True contraindications would look at things for patients who, some of our patients are too unstable to move. So there are patients in the ICU that the moment we touch them, their blood pressure drops, their heart rate increases, their oxygenation is no good. So there are true contraindications, but they're, for the most part, they're far and few between. And then we needed to also support staff to have a decision-making support tool to see, okay, I'm going to move my patient. How am I going to do it safely? So we had a stepwise protocol that helped them guide through mobility slowly. So whether it started off with, turning and transfers to the chair, and then slowly worked our way up to walking. It wasn't the first step. So we did a slow, steady transition through the different levels of mobility until we were walking with our patients, just to make sure that they were safe. We also needed to celebrate our successes. We've done a lot of work. We were actually able to reduce our number of ventilator days, reduce the length of stay in the ICU with this work, and to increase the overall improvement in our patients' health. Next slide, please. As part of the quality initiative, we wanted to really have a powerful visual. So we had a traveling whiteboard that went around our unit that was a very large poster of what you see. So we had the cookie cutter sheets, is what we called them. And it was a way to visualize and for staff to see what was going on in the unit. So the cookie cutters represent the bedrooms or the patient numbers. They were colored green if they were mobilized. They were colored red if they were not mobilized, but there was no contraindications, and then they were given a purple color if there was a contraindication. So there was slow buy-in to begin with, but once people started seeing the colors, they were so engaged and they were so willing to mobilize because they didn't want to have the red gingerbread man on the board. So they were really proactive in, no, wait, don't color my guy red. I just got him up. We just did it. I was late, but he's mobilized. And they were so engaged and so proud of the work they were doing. Next slide, please. We decided after the success of this mobility Mobilize Me project that we needed to start looking at those who we thought had contraindications. So we have patients in the ICU who are very difficult to mobilize. They're very unstable. I'm not sure if those listening are familiar with CRRT. It is continuous renal replacement therapy. So basically patients who are too sick and then too unstable to tolerate normal dialysis will be put on a very slow, continuous 24 hours a day, 7 days a week dialysis. The ICU nurses will manage this along with the ventilator and all the other drips. So we decided that we were going to mobilize these patients. So the next project was called, "You Want Me to What?" mobility and the CRRT patients, and the look of that nurse's face is often one that I saw whenever I approached bedsides with my next mobility project. Next slide, please. I'm very happy to announce, though, that we were able to create a new protocol and algorithm that was designed specifically to mobilize these patients who were identified as being unable or difficult to mobilize. We ran a pilot project last year and successfully saw 11 CRRT patients mobilized without any safety incidents whatsoever. So we're very proud of this work, and we are continuing to build on this. Next slide, please, and I'll turn it back over to Karen to share her experience with the Nova.
So I'm going to tell you about sort of our experience at the QE2 ICUs in Halifax. And I think one of our key messages is that the change is a process and not an event. So if we're looking for sometimes we learn so much through the process, and it's so valuable. So this was a big project for us. So took us a long while. Like Sarah described, this is a culture shift. And so it's not just a matter of buying a new toy and putting it at a bedside or doing a simple education strategy and away you go. It is a big culture shift. So our initial work was to look at what our current mobility looked like. We all felt like we had a sense of how we were mobilizing patients, and we knew that we had certain people on our team that were keener and would always get patients up, and we knew we had others that didn't. So we really needed to understand what current mobility looked like. So we spent a lot of time examining what our current practice looked like. Then we looked at the literature and did an environmental scan, including looking at resource models. What did other Canadian centers have for physio, for occupational therapy? Did they use patient attendance? Really trying to understand, how do people make this fit into their daily work? And it was in that time that we identified the Fraser health work, learned of their successes, and learned of sort of that protocol approach, that algorithm that Sarah had described. And there was a commitment at that time to move forward, building on the work of Fraser Health. And this initial group proposed an interprofessional best practice approach. In our second phase was really getting into the nitty-gritty of the planning. So in that phase one, that was sort of more of our, we had some high-level leaders on that. It was involved resource allocation. So we needed some decisions from sort of senior leader to support it. Once we get into that second phase, this was really the nuts and bolts. How are we going to do this? This is really planning the implementation, and how are we going to evaluate? And how is this going to integrate with our other quality initiatives? Because we just can't keep adding on. We need to find ways to dovetail, work together. And so when Sarah described to you that A to F bundle, this truly was this was our big dovetail. So this was going to help us with that, with managing delirium. It was going to help us. Patients were going to be awake more. I was going to get them breathing quicker. It was going to integrate with all of our other quality priorities, with how we were preventing pressure injuries, or how we were lowering our falls rate. And because we knew this was going to be such a culture shift, and it was so important for the work to be integrated at the front line, it was led by ICU nurses. So we had bedside nurses that took leadership roles in our two main ICUs to lead this project. We support, as more formal leaders, we supported them. We had a strategy to help make sure it was successful, but they led shoulder to shoulder with their colleagues. And this was largely RN, physio, and respiratory therapy. Part of this was looking at our current equipment and needs, and no, we didn't have a whole lot of money, and no, we don't have ceiling lifts. So we had to figure out a way to do this safely and effectively. So there was a lot of work went into that evaluation. And a lot of work went into the interprofessional education. And that education was not just how to mobilize, but it was reintroduction and reintegration of, how do I assess delirium? What's my expectations about delirium assessment? How do I assess sedation and agitation? And how is that sedation and agitation tied to what we're going to do for mobility for my patient today? In the second phase was really that's where the rubber hit the road. It was really the implementation and the evaluation. And there was those frontline leaders that really led this work. They led the implementation, they led the evaluation, They did the gap analysis and figured out when something wasn't working. And it was really frontline peer modeling and coaching that led us to success. Where we are now is really, we are in that ICU early mobility culture shift. We have a group of staff that has really drank the Kool-Aid on this, and it is an expectation that we mobilize our patients. And we're into now more in a role of supporting, of sustaining, and of sharing our practice. We really looked at that changing flipping our mindset from patients being too sick to get out of bed to being too sick to stay in bed, and recognizing that this simultaneous ICU care and rehab is the way that we're going to improve outcomes and improve long-term physical and cognitive recovery. This is really busy. I just wanted to show you that this was sort of our protocol. So it was very, very strategic about how we assessed what level a patient was in. It was tied to a validated agitation and sedation scale, and what the criteria were for when physio needed to be involved. And then the progression of mobility. So like Sarah described, everyone's not getting up every day and walking. There is a progression, and it goes from turning and in-bed mobility and passive range of motion to active range of motion to, once we're getting into more strengthening exercises and balance and coordination exercises and mobilizing. And then a big piece of this as well was how to assess, the constant assessment, how to assess that we were doing it safely to make sure the patient was safe, and that we minimized any risks to the patient sort of physiologically or from a fall, when to seek further clarification. All important. So a blurry picture down there in the corner, but that's one of our ventilated patients being mobilized. So evaluation. So was it safe to work? We implemented this without a really robust, we don't have an electronic health record. We have limited usable data. We have little pockets of data that don't tie well together. So we really needed to think about how were we going to measure our success and make sure we did this safely. We had to make sure that what we measured was important to our staff, because we knew there would be people that would be concerned about the safety of this process. So we knew that we needed to make sure that protocol was safe, that what we were doing was safe, but B, to make sure that we had the right engagement and we were actually doing it. So our evaluation spanned 18 months from implementation, and really looked at two things. One was the safety events. So this was things like accidental removal of patient support equipment, NGs, Foleys, lines, endotracheal tubes, that sort of thing. So we measured that. We measured falls to the floor. We measured if hemodynamics and stability. So we had very set parameters for heart rate and blood pressure, so that we could measure if a patient had an abnormal response or an unanticipated response, because we do anticipate some response. And we also had parameters for respiratory rate and oxygen saturation. So at the end of that 18 months, we were able to demonstrate that we were very safely able to mobilize these patients in a high acuity ICUs. And we also were able to demonstrate that we had progressed from in-bed mobility to out-of-bed mobility. The other piece, because delirium is a big focus of our daily work, is that we measured the percent delirium days so that we could see if we were actually making a difference. And we knew that we had documentation that the number one strategy that I can do to prevent delirium or limit delirium is mobility. There is no golden pill. There is nothing pharmacological that's shown the success that we would like it to. We wish there was, but there isn't. But mobility is that golden pill. So we were able to demonstrate that we were able to reduce our delirium days as we implemented this project. As well, built on the work of Fraser Health and the adaptation of their mobility protocol to contribute to a new body of knowledge. So really looking at mobility in the ICU trauma patients. There's not a lot of information around this specific patient population. So we really wanted to understand this better. So one of our ICUs is a trauma ICU. So we did with our Trauma Nova Scotia colleagues, there was a retrospective study done of all of our patients admitted at our level 1 trauma center for 2 years, and we compared before the early mobility program, and then we had a 1-year transition period, and then we compared it to the 2-year period afterwards, and we've demonstrated that we had a lower in-hospital mortality from around 25% to 17.5%, and a lower ICU mortality, so from around 21 to about 13%. So this is the first study to demonstrate a significant reduction in trauma mortality following the implementation of an ICU mobility protocol. As part in the middle of all this, or actually I guess it was really after our practice was well established, we had our Accreditation Canada survey visit, and we had really used mobility, as I said, to be our integrating strategy. There's a lot of unique factors within the Accreditation Canada standards that relate to critical care, related to delirium assessment, related to sedation assessment, related to how we ventilate or let patients breathe on their own. And then there's the pieces that we all have around pressure injuries, around family engagement, around falls prevention. So we used mobility as our integrating strategy, and the surveyor in the final report said that commented on the excellent uptake that we had within our units, tying all of these initiatives together with the key integrating strategy being our dedication to early mobility, and advocated that we work to spread this good work. So presently, the early mobility program in our Nova Scotia Health Authority ICUs is being spread across the province. It's currently part of a CI Extra program where we're looking at how it's being integrated into another regional ICU, and then how that work will be spread across the province. It also aligns very nicely with our Choosing Wisely work. The critical care Choosing Wisely recommendations include that we do not prolong mechanical ventilation by the overuse of sedatives in bed rest, and so that fits very nicely with our early mobility work, and then also includes a daily assessment of breathing. So really integrates well with our Choosing Wisely work. And also a big piece for us now is around advising and supporting our non-ICU environment. So looking at how can we educate our post-ICU colleagues around post-intensive care syndrome, and what can we do to support mobility in our patients outside of the ICUs. So mobility as a falls prevention strategy. So we're at a point now where we definitely have the research evidence to support the safety and effectiveness of mobility. We know that it reduces mortality, we know that it reduces morbidity, and it's been proven in many populations and settings. So we're at a great stage where we have a very common sense intervention that patients and families are keen to be involved with. It's also very encouraging now to see some safety advocacy organizations coming out with changes to falls prevention, like the IHI, and recognizing that forced immobility does cause harm, as Sarah has covered already, and that we're starting to really look at the relationship between delirium and falls. That if you have delirium, you're up to 5 times more apt to fall, and the importance of our non-pharmacological delirium interventions. And the number one non-pharmacological delirium intervention for us is early mobility. Really helping us to refocus from our former strategies of signage and bed alarms, and looking at the role of a sitter and how can we turn this around to support patients to get moving. So some of, I think, our big key factors are that everyone is busy regardless of where we're working, and so we really need to look at strategies to integrate for success. Early mobility for us has been a true integrating strategy. It takes pretty much all of our evidence-based practices and sort of everything that we know that we need to do to reduce morbidity, and ties it up with a bow for us. And also, I think another key message is that the infinite capacity of our frontline staff. Their knowledge and their leadership capacity is endless if we can leverage that to help us in our improvement work. And that is it from Sarah and I.
Wonderful. Thank you so much, Karen and Sarah, for your presentation. I'm going to remind all of our participants right now that if you would like to type a question, you can do so in the Q&A. If you're not seeing the Q&A button, if you hover over your main screen, you should see a black menu bar appear at the bottom and then the center, and you can click that Q&A button and submit your questions that way. And I'm just going to share my screen here. So that you can all see that we are open for questions.
I see a question about would we be willing to share our PowerPoint there, and that's absolutely. Sarah, maybe we'll make sure we don't have too many acronyms in there, as I noticed a couple when I was doing my slides.
Sounds good.
Yes, and I'll clarify for that as well. We will, I will follow up with the webinar presenters, and once you have your final slide deck, Sarah and Karen, you can send it to myself. I will be PDFing the documents, and they will be made available on Loop. So if you're not yet a member on Loop, please go ahead and register at fallsleep.com, and you will receive a link in a follow-up email from Zoom with a URL that'll take you to the archived webinars where you can access the slide deck, as well as the YouTube link for the webinar recording. We do have a question from Jennifer Johnson. Can you please share the algorithm for mobilizing patients on CRRT?
Yes, Jennifer, if you, I'm going to put my email into the chat box. If you want to email me directly, I'm happy to send it to you.
Wonderful. Thank you so much, Sarah.
It was, Jennifer, also, if you subscribe to the Canadian Journal of Critical Care Nursing, it was just recently published in there as well, but I'm happy to send it to you.
Perfect. And I'll just type in your email there to Jennifer. If there are any other questions, please continue to type them into the question and answer box on your screen. Perfect. I have a comment in the chat box. This presentation was amazing. I learned a lot about ICU that I didn't know. Thank you so much. This is great knowledge for those who are working in the field and great new learning for those of us who work elsewhere.
Well, thank you.
Another comment from Justine, great presentation. Thanks for the information and your time. From Justine, who's a rehab assistant at Valley Regional Hospital in Kentville, Nova Scotia.
Yep, that's one of our cool models, I think, Justine, that we're looking at different resources of how we can use our local resources to best suit our clinical needs. And so Kentville has really looked at how to use a rehab assistant. Eh, Justine? Everywhere is a little different. The important thing is to make it happen, I guess.
Yeah, and Justine has just also added in the chat box, yes, it's going great.
Yeah. Yeah, and I will say that, you know, that was one of our learnings. Like, we were kind of interesting that we did it in 2 different ICUs at 2 different sites at the same time, and you know, and the advantage of that was that we really, and they were done by, we did them together. We have one group of physicians. We have very similar care models, but the populations were a bit different, and we had some different resource allocation or staffing differences in each site, and it really was very insightful to see that we needed different strategies in different places. So I guess what I'm trying to say is that there is a strategy that will work for your clinical area. It's a matter of being creative and figuring out what's going to work in your clinical area. And I will tell you that the commitment, one of our ICUs, when we had just nicely, you know, launched this and really got going, and we had a quite a catastrophic flood in one of our ICUs, and we had to basically we moved out of that site for a while, and we opened up 2 temporary ICUs in 2 very what would the word be? Less than ideal environments. So very, very limited space, very hard to store any extra equipment, just very hard to even get chairs in at bedsides to get patients up. And I tell you, that was probably one of the most affirming things for me as the quality leader at the time, was to just see that there were no excuses. Like the staff was committed that that mobilization is as important as an antibiotic for a septic patient, and that patient will be mobilized. There was no way that wasn't going to happen. And so it's not all easy, and everyone needs a different solution, but I really think that it's being creative within your own resource models. Sarah, I don't know if you had similar sort of experiences.
Yeah, we definitely, once we got people on board and engaged, there was definitely, they were all in, they were very passionate once we sort of got past the initial, you want me to what?
Yeah. It's pretty fun now.
I'm just noticing that in the question answer, Julie's asked a question. We have a strong delirium early mobility initiative at our hospital. It's been a challenge to engage nursing. She likes the gingerbread man idea, and I'm wondering if that was nursing or physio initiated. It was actually nursing initiated, Julie. We did have our physio supervisor and our team of physiotherapists engaged in the project. So they were definitely there to help support and encourage the staff. There was one of the sort of misconceptions that we encountered, because we had such a great team of physios that worked in our unit, that it was physio's job to mobilize patients. That was one of the culture shifts and barriers that we actually had to break down right away, was that it was everyone's responsibility to mobilize patients. And so we really focused, working with the physiotherapists, to focus on having them help us with the hard to mobilize, or the ones that maybe had a period of prolonged bed rest. And so we wanted to know where on the continuum of the algorithm should we be starting and how to do it safely. So the physios definitely were engaged and were supportive. The gingerbread man, we had a large rolling whiteboard that made its way through the unit, and we did daily afternoon quality huddles so that people could see kind of what was going on, and that the visual, especially the colors, was a very big factor in engaging people. They really wanted to see their patient gingerbread man be green, so people were very keen to engage with us on that.
Yeah, and to further comment, when we launched this, we had one of our sort of first strategies was to understand how well we were doing with delirium assessment, and we had one unit that was doing much better with delirium assessment than the other, and we had to launched into figuring out why, and that it was partially related to the neural population and people's sense that was the tool valid in the neural population. So we had provided a lot of education to our nursing staff so that people really felt equipped with the right tools, so that the information they had was valuable, and then really helping them to understand the impact of delirium on patients' long-term outcomes, and that was just as important to treat that as it was the sepsis. We also introduced it a lot into our language. So we removed words like, we tried really not hard to not say, confused or agitated. If they were delirious, we tried to use the word delirium. We introduced it into all of our shift reports, into our charge nurse reports, and our charge nurse asked every shift, is your patient CAM ICU negative or positive, or are you unable to assess, meaning they're too sedated? And then we really engage with our physician colleagues on rounds to help reinforce that. So we really tried to come at it from a lot of angles, but I think the education was a big piece of it really becoming a thing that our staff has become passionate about, delirium.
We've got another question from Jane Walters about what to do when you trial reducing sedation to keep the patient from getting up when they're not supposed to.
Great question, Jane.
So great question, and really a challenging one, definitely. So as we reduce sedation, the idea that if the patient is really restless and agitated, before we reinitiate the sedation, we try and look for, is there other causes for the agitation? So are they in pain? Do they have an unmet need? And then if they do need sedation, trying to restart it at 50% of what they were on, and then titrating it till we get that happy spot where they're safe but not deeply sedated. We definitely, like Karen mentioned, we were looking at more use of sitters and families, and trying to support patients the best we can without heavily sedating them. I think sometimes as nurses, when we watch the patient be restless, or sometimes they're reaching for tubes, we're very quick to try and protect them. And it comes from a really good place, but I think sometimes we forget that, you know, they may be reaching to scratch their nose. It may not be that they're reaching for their, you know, endotracheal tube. So I think sometimes we need, and especially in ICU, because we're typically one-to-one nursing, it's just being at the bedside with the patient just to see what it is they're going to do before we resedate, just really making sure that that's what they actually need. And then if they're trying to get up, again, looking at, do they have an unmet need? Like, you know, if they're fully catheter kinked, do they have to have a bowel movement? Are they thirsty? Do they need their mouth care? And then of course there are patients where we need to sedate them. And so again, just working with them to gain the optimal amount, which is sort of the bare minimum to get your clinical goal. So whether that's to breathe easily with the ventilator, or what that might be. But great question, Jane, and definitely one that doesn't have an easy answer.
Yeah, and really looking at that BPMH and understanding, because it's certainly happened to us a few times, Jane, that one of the things we were missing sometimes was that we hadn't restarted something that the patient was on at home, or they had some pre-existing used substances that weren't on a medication profile that we didn't know that we weren't replacing. So really trying to look at that holistically, and involving our pharmacy colleagues too, and helping us figure that out. And again, back to that choice of analgesia and sedation, really trying to figure out that we picked the right analgesia and the right sedation for that patient. Our sort of next frontier, and I think Sarah's a little further ahead on this probably than we are, but is really around a real protocolized approach to analgesia and sedation, so that we truly are treating the pain first before we're reaching for the sedatives. So not having, when that admission comes, if unless there's a reason that I have to have them completely sedated, like they just had a big resection of their neck and I can't have them moving that resection for a little bit, not thinking everybody initially when they come from the OR has to be that quiet. So really trying to look at that protocolized approach to analgesia and sedation. Analgesia first, bolus doses first before we reach for the infusions, and then similarly with the sedatives. And then really as well with that piece, it is really questioning our use of restraints. Now there's some ICUs that use zero restraints, and there's some ICUs that use almost 100% restraints, but really starting to understand our restraint use, because that does contribute to delirium and agitation.
Yeah, and that's a great comment, Karen, and we're actually looking at a protocolized approach as well. And in preparation for that, I'm just in the planning phases of planning a new research study to kind of look at the factors that inform nursing decision-making, so we can better understand what causes one nurse to reach for one particular drug over another, and is there something that we can do to help in the protocol to make the choices more relevant to the patient in a more stepwise approach. So.
Thank you both Karen and Sarah so much for your detailed responses. Sarah, I did just want to point you back to Julie's question. I think you did answer that it was a nursing-led initiative, but where was it posted in the unit? And she's referring to the gingerbread man cutout.
So the whiteboard was a rolling big poster-sized board. It was on wheels, so it actually moved around the unit. We did mini quality improvement huddles in each of the pods. So we have 4 pods in our ICU, so it traveled from pod to pod in the afternoon. And when during the day when we weren't rolling it around, we have a wall in our ICU that's a quality of initiative sort of learning wall, and so it was parked by there right outside the staff break room, so people could see it coming and going.
Amazing. Thank you so much for clarifying. I just want to say a huge thank you again to both of our presenters, Karen and Sarah, for speaking on such a unique and a topic that's not really very popular out there, especially as it relates to, fall prevention. I know on Loop we've seen this question asked maybe a couple of times, but there is not much discussion on it because perhaps there aren't too many people that are addressing it in the way that you both are. So thank you so much for sharing all of your practical tidbits of experience and what you're doing in both of your areas. It would be really great to continue this discussion on Loop. So if anybody has any questions after this webinar, please feel free to start discussion on Loop. There is another question that just came in from Amy, a question about the reduction in mortality in the trauma unit. What type of mobility interventions took place?
It was that mobility protocol that I described that we adopted from Fraser Health. So we use their patient, we call it the RAS scale, but it's an agitation sedation scale, and as a key strategy to and then the patient's acuity or ability to our assessment of how they're going to respond to mobility, to rate them as a level 1, 2, 3, or 4, and generally they progress through those levels. But it's that protocol that I kind of had up on the slide, Amy. And if you want, I'm happy to send that to you. The manuscript currently is it's pending publication, so I can't kind of share that piece with you, but I can we're certainly happy to share our protocol.
Perfect.
It's right from that level 1 is basically embed mobility and positioning, to level 4 is that up and getting the patient around the unit, like the pictures there that Sarah and I showed.
Amazing. Thank you very much, Karen, for that response. I am cognizant of time, and we are a minute past 1 over here. So I will thank all of our participants for joining us on the webinar today, as well as our panelists, of course. For more information about the fall prevention community of practice, please visit Loop at www.fallsloop.com. You can find the URL in the bottom right of your screen. We've also launched a new online community of practice for children's fall prevention, Loop Junior. So if you have a passion and interest in children's fall prevention, you can join us at www.jr.fallsloop.com. I would also like to remind everybody that November is Fall Prevention Month, and we do have a few webinars lined up for the summer in preparation for the fall. This year, we are attempting an activity implementation webinar series. So these are meant to be short webinars that will start with an update on the Fall Prevention Month website, how you can navigate it. It will show you what sort of promotional materials and things you can do to take action for the month of November. And we will have a guest speaker at every webinar that will discuss how they have implemented a different activity in their area. And I will be, I've just put in the URLs for the registration for those webinars there. So if anybody is interested in how they can implement any of these activities, please feel free to register for the webinar and join us for that discussion. When the webinar has ended, you'll be redirected to a new screen where a brief evaluation survey will launch in your browser. We'd appreciate if you could provide us feedback so that we can continue to offer high quality webinars like the one that we just experienced. Thank you all very much and have a wonderful day. See you next time.
Thank you.
Thank you.